would like to show you a TAVI case. So clearly this is a patient with severe aortic stenosis, and I would like to take a couple of minutes here to present the patient. The patient is 79 years of age, gentleman, normal body size. He is like 171 or 172 centimeters in height. He has BMI of 30. He's known with history of high blood pressure, hypercholesterolemia, paroxysmal atrial fibrillation, and he was followed for severe aortic stenosis, which became symptomatic, and he was referred for for treatment of that. He has NIHA class 3 symptoms. He also had CCS2 symptoms and had recently received a PCI in the mid-LAD. He also received recently a pacemaker implantation due to the bifascicular block, which was seen as actually trifascicular block, which was seen as a major risk factor for third-degree AV block during our TAVI procedure. That's the reason he was given upfront a pacemaker implantation. Now, other issues: he has renal function with eGFR of 30. He has rather normal lung function. He has hernia in the left groin and BMI of 30. That's one of the reasons we would like to avoid punctures in the left groin. So our plan is to do TAVI using a transfemoral access from the right side. We will also use a right radial for pigtail catheter. We will pace on the LV wire. We were discussing what valve to use here. He has a very calcified native aortic valve with perimeter 79-78. An area around 480 square millimeters. He could get. Probably any valve would be technically feasible. We were keeping in mind his recent history of PCI, which is why we excluded a couple of one or two valves that maybe are less favorable in a patient who may require PCIs in the near future. We were also a bit concerned about some calcium present in the upper LVOT and heavy burden of calcium on the native leaflets. Mechanical complications were something we were aware of and a bit concerned of. So our final choice in this case was a Navitor valve from Abbott, which we hope will provide a hopefully good combination of sufficient radial strength, of sufficient efficacy in this calcified anatomy, and also reasonably good access to the coronaries in the future should that be necessary. Our concerns, so basically BMI 30 is some distance to cover from the skin surface to the vessel in the groin, so we hope, and also at the puncture sites of femoral arteries, and both sides actually there are at least moderate amount of calcifications, mostly medial and posterior. This increases the risk of closure device failure. Hopefully we can manage it and puncture in the calcium-free zone. Other concern is severe calcification of the native aortic valve, which may result in PVL, which may result in mechanical complications. We hope by doing careful pre-dilatation and post-dilatation, we may mitigate these risks. As of right now, we only have access with we have a 6-French sheath in the right radial, and we will now approach the right groin. So let me join my colleagues by the table here. We usually like to go in with a pigtail before we commit to a stiff wire. So let's go to less frame rate now. So we go back to 4 to protect ourselves from actus radiation here. So you can see the AL is in the left ventricle. We come in now with a long, soft wire. So it's a regular wire, just longer. And we will let the wire sit in the LV. We will come forward with a pigtail next, and then we will change to a stiff wire, in our case, safari wire. We're going to use, Alejandro, I don't have the wire, so you can walk it still carefully. I have the wire. Okay. Next will be pigtail. And of course, there's a variety. There's a choice of stiff wires. One could use multiple options. Our standard happens to be, just by tradition, a safari wire. Most of the time we use safari small or extra small. They are largely interchangeable. Most patients would be able to take any one of those. By the way, do we have also noradrenaline, just in case? Let's maybe connect that just in case, because that's something I typically like to do, because once we manipulate in the left ventricle, sometimes we have an issue with the blood pressure, and since we don't have anesthesia team, it's up to us to correct hemodynamic. I can see our systolic blood pressure is still around 110. It's all normal, but it's a good idea to be prepared, and noradrenaline is a first-line therapy in case blood pressure would have a tendency to go down. What's the ACT? Okay, so with efficient ACT, it's just around 100. So it's normally we aim between 250, just above the 250, or between 250 and 300. So we are right there. So you hold the wire. Pigtail comes forward. It's important to make sure that the wire is not entangled in some, mitral apparatus. So we'll try to. Usually, what I do in some cases, I slowly cross the valve with a pigtail catheter, and if I'm doubting wire position, that it may be caught in some cord, I would pull the wire back. It seems to be okay. Yeah, it goes to the apex. It seems to be fine here. So we'll try to accept this position. We pull back the wire. We'll also use the opportunity now to measure some pressures. It's not that we're doubting the diagnosis of severe aortic stenosis, but we also pay a lot of attention to the end diastolic pressure in the ventricle and compare it to diastolic pressure in aorta before and after valve deployment. This helps us to judge how significant or insignificant is a paravalvular leak. So let's, in a second, let's measure now. So we have end diastolic in the ventricle 12 and aortic 49, very high gradient. Invasively, it's 75. Let's do one more measurement maybe. So now we have a maybe smoother run without any extras. So let's measure now. Yeah, so we have the measurement nicely on a smooth segment. So even lower, so LV is 8 and aorta 50, the diastolic. So we can give some fluids there. It doesn't seem that the patient will be overhydrated. Good. So we are good to go. ACT is good. We have pigtail in position in the left ventricle. We have I will cover here this venous sheath here. We don't need to interact with it. Again, we also used venous access in the right groin here just because the left one is with this hernia, inguinal hernia, so that's one of the reasons. We will come with a stiff wire, and then we will come, in this case we will use, again due to BMI 30, sheathless approach is sometimes a bit more tricky, so we will use a sheath, and in this case we chose to use expandable sheath. This will be an iSleeve from Boston Scientific. It's quite well compatible with many valves, including Navitor, so that's what we're going to use. Otherwise, there's no major resistance. The sheath goes very easily on the wire, and as you can see, we have no extra systoles on the ventricle. This normal heart rhythm, you can use that to judge if your wire is in any way aggressive on the ventricle or not. So everything is very calm, nice rhythm. The nurse is communicating with the patient, and the patient is informed that it's normal. If there's some discomfort in the groin, the sheath is in. And as you can see, there's no signs of any kind of station to the ventricle or anything. And we have full control. Now, Alejandro is removing here the dilator, also watching the wire so that we're not pushing too much, on the ventricle or anything. And we are almost done. That's it. I have the wire. Next will be balloon on the wire, okay? Now, Alejandro, I'm not holding the wire. You have the wire, yeah? Let me flush the big sheath. We connect pressure set. We will flush the big sheath here. It's important, indeed, to remove all the air and things like that from the sheath. We have checked ACT, that was completely normal, so that's also good. So since the valve is so calcified, we will for sure do a pre-dilatation. We were discussing what balloon should we use for pre-dilatation, and there can be different ways to size it. The most usual way to size it is to take a balloon which more or less matches the minimum diameter, the smaller diameter of the aortic valve annulus. Alejandro, you watch your wire now, yeah? Sometimes we use another logic where we say, so what's the maximum? What's the perimeter-derived diameter of aortic valve? What's the maximum balloon we could safely use? In this case, it's 25. And then you subtract a couple of millimeters from that number. So if perimeter-derived diameter is 25, gently pull back, because now we see a little bit of ventricular irritation. Gently more pull back, like this. Like this. This is nice. This I like. So we took a 23 balloon, which is 2 millimeters smaller than the perimeter derived. Now we will pace on the left ventricular wire, and for that the setup is the following. We connect one pace lead on the LV wire, and the other pace lead is connected here. Not sure if it's visible, but it's also connected on a wire inside the vein. Okay, so it can also be connected just to a needle in the skin, but we find it nice to just put a wire in the venous sheath, and we use venous sheath anyway because we use it for medications. If necessary, it functions as a kind of a central venous line. So these two places where we have connected, you take the syringe, Alejandro, we have connected these two pacemaker cables. We will do maximum output, and we will go 180. And let's go 7.5 frames per second, just now so that it's maybe better visible for those who are watching. And so is pacemaker ready? Pacemaker on. Let's see if there's capture. There's a good capture. Pressure down, balloon up. Pacemaker off. We'll redo it. It slipped up. Okay, let the patient recover. So we'll redo it. Patient has recovered, so okay, pace on again, 180. I'll try to be slightly deeper, so good capture. Pressure down, go up with the balloon, go up more, go, go, go. Oh yeah, oh, pace off. Yeah, it's really, really calcified anatomy, man. So we do one more time. So we are again already across. Let me yeah, there's one option to pace a bit faster. Another option, I'm trying to decide is the wire good, so I'm trying to reposition the wire once using the balloon. Just the tip of the balloon. Because I'm not sure that wire is optimal, so let me just try to reposition it once. Okay, let's try to pace 180. Pace on. Okay, so good capture, balloon up. Yeah, all the way. Now we have a good expansion. Good expansion. Pace off. Oops, and fluoro save. All right, good. So let's walk it out. Good. So, all right. Let's go to LAO projection just to open up the arch a little bit. There is no specific marker, you know, in contrast to some other manufacturers that you would want, that we would have to obey when you cross the arch. Basically, we keep flushing port, in this case, at 12 o'clock position, and as we cross the arch, but to check against. Now, Alejandro, you rail me very gently. Don't let that wire sink too deep. I would pull gently back on the wire. Put a bit more, pull a bit more. And the capsule is very flexible, so typically it navigates most arch anatomies rather easy. As you can see here, it does its way without any major problem. That's good. So fluoro save that. And now I will go back, maybe initially to the cusp overlap projection, which is RAO 10:15, to see how are we looking there. We are pretty good. We're not yet in position. We're still a bit higher. Let's hold the wire. Maybe pull that wire a little bit back, because I think we're a bit deeper, like this. This is perfect. Let's flip the wire now, and let's connect. We'll again connect the pacing lead on the tip of the wire, because that's how we pace, so that we don't forget it, like that. Pressures are good, just like 110 or so. We go slowly forward. The pigtail is sitting, you see, in the non-coronary cusp. So we are more or less in position. Before starting the release, I will do one more check. I will go back to LAO just to see, is the valve in LAO view, is it very much on the outer curve or on the inner curve, and I have an impression that it's actually very much on the outer curve. Disable once, disable. So we'll do just a dry run here without any contrast, so we can see that the valve is, it appears to be completely on the outer curve, which is why we will probably let it sink slightly deeper as we deploy, and then we gently pull back so that we can centralize the top of it. And we do it slow. Patient is stable, systolic pressure 115. It's all nice and stable. And the aim of what we do is to make the valve slightly more vertical, less against the outer curve. And the aim was to have it a tiny bit deeper compared to the first projection, to the first attempt. So we'll see if this is going to be... Did it dive a bit too deep here? I have a feeling it's now diving slightly too deep. So let me immediately partially recapture, because it's not the aim to be super deep. We still want to have those 5 millimeters or so, but we don't want to have just 2. So probably somewhere around here. Yeah, don't push on the wire, don't push. Yeah. And let's stop pacing. We'll check it here. Let's see what we got. Flora, save that. Good. So it's clearly more vertical. That's for sure. That's for sure the case. Let's do a shot. So it's lower on the left side. That's certain. And it's more central in aorta. So I'm pretty happy about the left side. There's no leak also. Now we'll check the non-side. Again, we come back to the cusp overlap, which is RAO 10, caudal 15. Let's see how this looks like, because here is the best projection to judge the non-coronary side. Let's check it from here. It's pretty good, pretty good. Like I don't expect the valve to tilt, clockwise. If anything, it should tilt counterclockwise, because from this projection it's even more to the inner curve. And if we play back once, yeah, also on the left side, I don't think we are too deep or anything, so we're pretty central here too. So let's accept it here. Let's go for release in that case. So you relax the wire. I kind of try to stay neutral here. Let's maybe pace 140 or so while we're releasing. You guys agree, or would you do something? Yeah. Yeah. So I push gently forward to just maybe neutralize any backwards tension, which I may have. Yeah, there we go. So it's almost released. Almost released. Still a couple of, and we can stop pacing. Flora, save that. Yeah, I don't see any trace of leak. A descending aorta is nicely opacified a couple of seconds after the injection, and we have nothing next to it in the LV cavity, like not even a trace from this injection. Okay, so there could be something on echo maybe, but very good hemodynamic result, no visible leak on the angio. Tells me that there's nothing else we should do about the valve. We can certainly accept. We can do one dry run from LAO just to visualize the shape of the valve. So I will go to the same LAO 40, LAO 40 projection just to show. Look at the frame. How is it? Is it constrained? Is it expanded? Just to have some understanding there. But I don't think we need any supplementary injections or anything. So the frame looks like that. Let me do a dry run here. Yeah. So at the annular level, it's completely expanded. Again, we don't see any struts that would be constrained, and all the way to the posts, it's expanded. It's slightly more constrained at the ascending aorta and STJ level, but that's not the purpose to treat that with any kind of balloon. So we're pretty good. I'm happy.